Thank you so much for this introduction, Anna. Thank you for giving me the occasion to speak. I'll be very happy also clarifying some of the issues that Melba already pointed out, because of course we were together with WHO in this epidemic. I also want to say I'm not an ethicist, I'm not a clinical trial specialist. I was a bit thrown into the deep during the epidemic. I'm a clinician, I care for patients. And also my case study is a real patient. I'll come back at the end, but we got permission also of the father, because the case study is mostly about the baby, but also about her mother. We got permission of the father to tell the story of his daughter. And it's also a story, what happens, and I don't think I need to warn the audience for this, but what happens if you exclude pregnant women from research? Of course, Ebola is an extreme example. There are not that many, actually I don't know of any disease in the world that has a more than 50% mortality in this epidemic, up to 90% in some groups, and all this within the time span of around 10 days. Because after 1 week, you know how it's, well, you know for almost all patients how it's going to go, death or alive. Of course, untreated HIV also has an extremely high mortality, but this is over a period of many, many years. Ebola is quick and is very often also very, very clear how things go. So the setting, we go to West Africa. In dark brown is the places where there were a lot of cases, light brown where there were not so many cases, but just to show the whole of Sierra Leone had cases, the whole of Liberia had cases, and almost the whole of Guinea. There was also extension of this epidemic to other African countries, Nigeria, Mali, and Senegal. In Nigeria, miraculously, they managed to stop it. It was in Lagos, a city of 20 million people. It's really respect to the Nigerian authorities that the virus was stopped there. And also extension of the epidemic in Europe and in the United States, mostly because of evacuated healthcare workers. And so this is what happened in the epidemic. It's a time span from March 2014, when the virus was identified, to the end of 2015, the end of the epidemic. Afterwards, there were still what is called flares, a few people who got Ebola, but the official end of the epidemic was in October 2015, and we also go for the case study to the end of October 2015, exactly 1 year ago. If you see the number of deaths, this peaked in Liberia, the red line, in August 2014. It was also when WHO said that this was a public health emergency of international concern. And there was a second peak in Sierra Leone in December, January 2015. And in Guinea, the caseload was lower, but Guinea was the country where the epidemic dragged on the longest. We had the peaks in Liberia and Sierra Leone, but we had, like, long time, a quite low continuous caseload in Guinea. So the mortality, at least 11,000 deaths. This is WHO figures. We know that the mortality figures are not 100% reliable, but it's what we have. Cases, we had around 28,000, but cases was also probable and suspected included. So even those data are not 100% exact. And MSF, my employer, treated 5,000 confirmed patients during this epidemic, which is around 1 in 3 of all the confirmed patients. So I'll go quickly about this because Melba already announced it. In the particular context of the current Ebola outbreak in West Africa, it's ethically acceptable to offer unproven interventions where we just had like preclinical animal studies and not a lot or almost no data on humans. So the whole normal process of like clinical trials, which you all know much better than I do, from preclinical data to phase 3 trials, which normally takes years and years, got speed up in 4 months. So MSF was involved in all of the major clinical Ebola trials, apart from one, the ZMAP trial, We administered favipiravir, we administered brincidofovir. Favipiravir was Guinea, brincidofovir was Liberia, convalescent plasma was in Guinea, and we were involved in one vaccination trial, the VSV vaccination trial, where WHO was the sponsor. One of our frustrations, but maybe also unavoidable, was that we were there late in the epidemic with the drugs. If you see like this peak in Liberia, with more than 1,000 deaths in a very short time span, we didn't have anything to offer to the patients. So when the epidemic was going down, we had the drugs. But also on the other hand, I also think it's almost a miracle to get from preclinical data to phase 2 trials in 4 or 5 months. So I'm not sure if we could have done better. So the interventions were selected on a few criteria. First of all, efficacy and safety. As said, data were limited. Antiviral preferred over host support in normal human languages. We wanted something that was active against the virus and not, for instance, like platelets or coagulation factors to make your body stronger. Availability and post-trial access possibilities. One of the reasons that ZMapp was not chosen was because it's made from tobacco plants and it takes 3 to 4 months to grow. And at that stage, there was almost no ZMapp in stock. So we said, if this turns out to work, we should treat everybody with ZMapp, but there is a problem in post-trial access. And also way of administration. Favipiravir and brincidofovir are oral drugs, which is easier to administer, and also with less risks for the healthcare workers. Not that it was a major issue, but still every injection is a potential risk for the healthcare worker if you stick yourself. Then also in Ebola, the first day that we had the Zika discussion, Ruth already mentioned it. To randomize or not to randomize, that's the question. MSF decided for several reasons not to randomize. So everybody in the trial received the potential active drug. What was done was we compared with historical controls. So patients of the same sex, same age group, and the same viral load, the same virus in their blood, who were treated in the same center 3 or 4 months earlier. So pregnant women, as Melba already said, favipiravir, Japanese company called Toyama. There was no insurance in the trial, so the first reaction was no pregnant women allowed, but then through direct negotiations with the company, we got the monitored emergency use of unregistered drugs in, and they were fine with that. Brincidofovir was a no-go from the beginning because indeed, in animal studies, if you give very high dose to rodents, they do more abortions. And convalescent plasma was no problem. Can I also say, as Melba already said, that up until the end of the epidemic, there had never ever been a baby who survived Ebola. There were some babies born alive, but they all died within 21 days of presumably Ebola. So all this, the teratogenicity discussion was mostly theoretical. Then the VSV vaccine trial where we were involved was not allowed in pregnant women, and in the beginning, in the protocol of the trial, it was children under 18, not under 6. This was later on amended. But in this trial, 7,000 people got vaccinated, but there was no standard pregnancy testing in this trial. So 20 women were vaccinated accidentally while pregnant because they were first trimester pregnancies and they didn't know they were pregnant. And from oral communication from the primary investigator, who is a Colombian, Ana Maria Restrepo, Henao Restrepo, she said last month that they followed up the pregnancies and that the babies were normal, as we would have expected. Of course, 20 is a very, very small sample size. The vaccine is a live attenuated vaccine. So, the results of the trial were out in August 2006, And the vaccine trial was was quite complex. Who was vaccinated? The direct contacts of Ebola patients and the healthcare workers. MSF was not involved in the trial protocol. We were involved in logistics, cold chain, people who vaccinated. And when the results were out in August, this vaccine seemed to have very close to 100% effectiveness. So now we go to the case. We go to rural Guinea in a province called Forikaria on the border with Sierra Leone. And Nubia's mother was a 25-year-old who was pregnant in the 3rd trimester. She cared for a woman in the same household who died of Ebola. The household structure was a polygamous marriage. So the husband was married to 3 wives, and the first wife died of Ebola. Nubia's mother was another wife, and she cared for her. So she washed her, she put her new clothes on. She was an extremely high-risk contact. Everybody in the household was vaccinated, apart from her and the 3-month-old baby, because children and pregnant women don't get access to the vaccine. And she developed fever and tested Ebola positive after a few days and was referred to MSF. The patient was in a bad clinical condition and had a very high viral load. We know now, we've analyzed almost all of the data, there are 2 things that really influence your mortality. One is your age. Small children and old people do badly. And the second thing is your viral load. The more virus in your blood, the worse you do. From just like, irrespective of the pregnancy, just with this viral load, she had a 90% chance of dying. We knew it already from the data that we had been analyzing during this epidemic. The baby was apparently alive. The mother reported fetal movements, but the baby was not really something that we were considering. We were considering the mother. Like at that stage, the baby was very, very far away on the list of priorities. MSF wanted ZMapp for her. There was a ZMapp trial ongoing in a center nearby. The promoter was NIH. In the ZMapp trial, pregnant women were allowed to be included. They did pregnancy testing, but also when you were pregnant, you were allowed to be included. No pregnant women have been included. But what was said by the center is, if you want the ZMapp, you must agree for randomization. So it means 50% chance of receiving placebo. So MSF didn't agree with this concept. We wanted the ZMapp, even though also data on ZMapp and effectiveness is, well, I think at that stage it had been given, the results of the trial were not out, but like to 20, 30 patients. So we didn't have a lot of data, but we said we want this drug for her. We don't agree with the randomization. And negotiations were ongoing. In the meantime, we administered favipiravir, which was also at that stage standard of care in Guinea. Because in the study called the JICI trial, where we participated, there is an improvement in mortality, but only for patients with low viral load. If you ask me, was it useful to give it to her? It might have helped a little bit, but according to the trial, it didn't make a major difference. So the mother went into labor and she delivered a baby a few days after admission, Nubia, 3 kg alive and well. And the mother died 7 hours after birth of hemorrhage and diffuse intravascular coagulation as a complication of Ebola. She was correctly managed. She received all the drugs. But like from her admission, she was in a very, very bad clinical state. She went into kidney failure. She was unconscious the 2nd day after admission. And we have transfused patients with whole blood bleeding patients in Ebola if we thought that the care was clinically useful, but here the care was estimated to be futile because the patient was in multi-organ failure. So Nubia, the baby, she received without delay first the ZMapp within 24 hours after birth. For her, there was no question about that she needed to be randomized. The center said, no, you will get the ZMapp for the baby. After some days, she received an experimental compound of Gilead Sciences. She was the second person in the world to receive this. Those of you who follow the Ebola data, the first person was a Scottish nurse who did a relapse after 10 months of Ebola and meningoencephalitis, and also a Buffy coat survivor. This is white blood cells of a survivor. And Nubia was 1 month in the Ebola treatment center, and she survived. So there are many issues for discussion in this case, not just pregnancy linked. But first, I'll say about the pregnancy, well, the availability of experimental drugs for pregnant women was complicated. For brincidofovir, it was impossible. For favipiravir, where we got then the monitored unregistered emergency use, it was a lengthy process. It took like a month, 2 months, and also it was not that we had nothing else to do apart from negotiating with the manufacturer about this issue. So potentially, pregnant women could be disadvantaged because they don't get access to potentially active experimental drugs. So just being pregnant in this epidemic could be a handicap, and was definitely because she was not vaccinated. And then also the second issue, ZMapp, once the baby was born, was obtained immediately. For the mother, the center insisted on randomization. So the baby seems to have been privileged compared to her mother. The reason why they didn't insist on randomization was that, well, all newborns up till now had died. They knew that Nubia would not be a good candidate for randomization because you have no one to randomize her with. And it was the end of the epidemic. While what MSF's argument was for Nubia's mother was, in the ZMapp trial, at that stage, they never had a pregnant woman. There was always also no one to randomize her with. And the trial, well, in total they had 72 patients in the trial, of which half received placebo, was done in 6 different or 7 different centers, one in the US, a few in Sierra Leone, and then in Guinea. The care between the centers was also so different that it's very difficult to say that the randomized controlled trials could have supplied very reliable data. So, and then the access for the vaccination, I think this is clear. Ebola is a condition with more than 50% mortality, and Nubia's mother did not get the vaccination. And then also an ethical issue that she was never involved in the discussion process. In none of the discussion processes, first of all, no one asked her, do you want this vaccine? Even though we don't know what it does on the fetus. The phase 1 data, there were no pregnant women, I suppose, in phase 1, but the vaccine had as side effects mild fever and arthritis, arthralgia in 10–15% of cases. And also, we didn't really involve her in the decision process, do you want to enter the clinical trial? We decided for her, we want a potentially active drug. To be honest, I think the day after admission, she wouldn't have been able to give consent anymore. She was unconscious. But also we didn't discuss with her husband. So this also definitely is an issue. So also to end on a happy note, Nubia became 1 year old last week. This is her when she was 8 months old. And yeah, her birthday is the 27th of October, but it's also the day that her mother died. And this leads me to thank mainly frontline workers and communities. I would like to thank Joe Mullen also for helping me with the case study. I would like to thank Annick Antierens of MSF, who was far more than I involved with all the experimental drugs. And I would like to thank the father of Nubia, who kindly let us use the story of his daughter and of his wife for publication and also for wider spread. Thank you very much.